Welcome to the Acute Medical Teaching Series. We are your hosts, Shifona
and Harrison.
both senior house officers from Salisbury District Hospital.
This is a 12-part teaching series running over the next 3 months. You can find links to our other sessions on our YouTube channel or via Blackboard for the local Southampton students.
This is our 7th session and we will be looking at diabetic ketoacidosis. Diabetic ketoacidosis, or DKA, is an acute complication of diabetes which can be fatal and therefore requires prompt treatment. As the name suggests, it is characterized by a triad of hyperglycemia, or raised glucose levels, ketonemia, or raised ketones in the blood, or ketonuria, which is raised ketones in the urine, as well as acidosis. It mostly occurs in patients with type 1 diabetes, but can also be present in type 2 diabetes. It may occur as a first presentation of diabetes.
So let's have a look at the pathophysiology of diabetic ketoacidosis. Insulin is a hormone produced by beta cells of the pancreas, which is responsible for driving glucose into cells. When there is a deficiency of insulin, glucose cannot enter the cells and stays within the blood. This causes high glucose levels in the blood whilst the cells are starved of energy. In order to counteract this, the body undergoes glycogenolysis, where glycogen is broken down into glucose, and gluconeogenesis, where glucose is produced using non-carbohydrate substrates such as proteins and lipids. However, this only further increases the blood glucose levels as the glucose is still unable to enter cells. Glucose overflows into the urine and causes osmotic diuresis, causing polyuria, which is excessive urination, dehydration, and polydipsia, which is excessive thirst. These are characteristic in patients with diabetes. Osmotic diuresis can also lead to the loss of ions such as potassium, causing hypokalemia.
When fat is broken down as an alternative source of energy, the fatty acids are metabolized in the liver and produce ketone bodies. These are acidic in nature and can result in metabolic acidosis when produced in large amounts. The acidosis can lead to hyperventilation as the body tries to compensate by blowing off CO2. These patients can also become peripherally vasodilated, leading to hypotension and hypothermia. The hypotension due to peripheral vasodilation and due to hypovolemia caused by osmotic diuresis, as mentioned previously, can lead to shock, which is life-threatening.
So when we think about management of DKA, we will need to address these complications. More on that later. Now let's have a look at assessing DKA. Starting off with a history examination, we would first ask about a history of the diabetes. So we'd want to establish if it was type 1 or type 2, and we'd also want to see if they'd missed any doses of their insulin or if they were adherent with their insulin therapy. And we'd also check for features of diabetes such as polyuria and polydipsia. We'd also look for signs such as nausea and vomiting, abdominal pain, Kussmaul's breathing, hyperventilation, signs of dehydration or reduced GCS. You can also check for hypothermia, and you may be able to smell acetone in the patient's breath, often described as the smell of pear drops.
When assessing the patient, look for any presence of risk factors, such as new onset diabetes, infection, or acute illnesses such as MI or pancreatitis, which are common precipitators of DKA, or any physiological stress. And also take a drug history to check for any discontinuation of insulin, either intentional or unintentional, inadequate insulin, or use of drugs such as SGLT2 inhibitors, which are more prone to cause DKA. Investigations needed include VBG to check the blood's pH, blood glucose levels, blood ketone levels, as well as a full screen of FBC and Us&Es to assess electrolyte levels and check for any signs of infection. Depending on the history and severity of the DKA, other investigations to consider include ECG, a full infection screen, CK, and amylase and lipase levels, which can be elevated.
Whilst assessing the patient, also consider other differentials such as hyperglycemic hyperosmolar state, lactic or uremic acidosis, starvation ketosis, alcoholic ketosis, and aspirin poisoning. Next, we'll be talking about the criteria for the diagnosis of a DKA. So we look at these 3 criteria. Firstly, we look at hyperglycemia with a blood glucose levels of greater than 11. We look for ketonemia or ketonuria, and generally this would be ketone levels are greater than 3 in the blood, or ketones +2 on a urine dip. And we also look for evidence of acidosis, so this is either going to be a bicarb of less than 15 on your VBG, or a venous pH less than 7.3 on your VBG.
We've now diagnosed DKA. What next? The aims of our treatment is to restore circulatory volume, correct any electrolyte imbalance, correct the hypoglycemia, clear ketones and prevent further ketogenesis, and to identify and treat precipitating causes as well as prevent any complications.
Firstly, we will start off with an A-to-E assessment and manage any life-threatening features identified. Then, looking into the aims of our treatment, to restore circulatory volume, the patient must be given IV fluids, and this should be started as soon as the diagnosis is confirmed. Fluid boluses should be given as the systolic blood pressure is less than 90, with early consideration of ITU and senior support. When the patient's blood pressure is greater than 90, they can be started on a 1 litre bag of sodium chloride over 1 hour and further replacement as required. Generally, we follow a 1-2-2-4-4-6 regimen, so this is 1 litre over 1 hour, then 1 litre over 2 hours, then 1 litre over 2 hours, then 1 litre over 4 hours, then 1 litre over 4 hours, and then 1 litre over 6 hours. When giving fluids, exercise caution in patients who are young, as they have an increased risk of cerebral edema due to fluid shifts, as well as elderly or pregnant patients, or those who have heart or kidney failure, as we do not want to cause fluid overload. Secondly, these patients will develop hypokalemia as a result of the insulin therapy we are giving them, as it will drive potassium into the cells, as well as driving glucose into the cells. Therefore, we need to often replace potassium in these patients. As a rough rule of thumb, if the potassium is greater than 5.5, they don't need any additional potassium replacement. If it's between 3.5 to 5.5, we should be adding 40 millimoles of potassium from the second bag onwards of IV fluids. And if their potassium is less than 3.5, we should be consulting ITU for more invasive methods of potassium replacement, such as a central line.
Thirdly, patients will need IV insulin. Patients in DKA are started on a fixed rate insulin infusion of 0.1 units per kilogram per hour. This should only be commenced after the serum potassium reaches 3.3, as insulin causes potassium to shift into cells and can lead to worsening hypokalemia. If the patient takes a long-acting basal insulin, you would continue to use this as normal. When the DKA is resolved and the patient is eating and drinking, they can be restarted on their subcut insulin. This is often started by the diabetes team as they get involved early in the patient's management. Bicarbonate and phosphate replacement is not often given, but can be considered if needed with senior input.
Next, we will be talking about some of the complications associated with the management of DKA. Firstly, we have hypoglycemia. As we give insulin to these patients, we drive down their glucose levels. But if we were to give continued insulin, we would risk making them hypoglycemic. Because of this, when their glucose levels reach less than 14, we start them on supported bags of 10% dextrose alongside their normal fluid resuscitation to make sure they don't have a hypo. Another complication is hypokalemia, and we've talked about this previously. As we give the insulin therapy to these patients, we drive down the potassium levels, and this can cause them to become profoundly hypokalemic. Because of this, we often give supplementary potassium alongside their sodium chloride bags. The third key complication of diabetes treatment is cerebral edema. This is especially prone in young patients, and this is because of the large fluid shifts we see when we're treating DKA. This can disrupt the blood-brain barrier and cause essentially large osmotic changes within the brain and can lead to resultant swelling. Therefore, in younger patients, when we're managing their DKA, we often are more cautious with the fluids and will do regular neuro observations to avoid this as a complication. If we are concerned, we will be ordering a CT head on these patients and escalating to a senior.
Patients will need to be closely monitored to minimize these complications and be treated promptly. Generally, glucose and electrolytes are measured at least hourly. Calcium, magnesium, and phosphate are checked every 2 hours. Urea, creatinine, and ketones are checked every 2 to 6 hours. These will vary depending on the patient's condition and response to therapy. The following criteria is used to determine the resolution of DKA. pH being greater than 7.3 and bicarb being greater than 15 and blood ketones being less than 0.6.
Patient education is vital in minimising episodes of DKA. Although often done by the diabetic endocrine team, things to consider in discussion include sick day management, information on when to contact a healthcare professional, the importance of good blood glucose monitoring and what the patient's targets are, and appropriate nutrition during illnesses. A close follow-up of these patients in the endocrine clinic will allow these discussions to take place. As you have seen from our video today, the management of diabetic ketoacidosis is a very complicated topic, and management consists of multiple steps that need to be taken. In situations such as these, it is important to refer to guidelines so you don't miss any stages of the management. The Joint British Diabetes Society Inpatient Care Group has released a full set of guidelines back in 2021, which gives a clear outline of how to approach the management of DKA, and we would advise using these.
Thank you for watching. Don't forget to fill out the feedback form in the description. We are your hosts, Shifona
And Harrison.
See you next time.